Hi, everyone. Welcome to this virtual session on emerging and re-emerging neglected tropical diseases. This is Matthew Romo. The learning objectives for this session are to describe neglected tropical diseases or NTDs in general, and specifically emerging and re-emerging NTDs. We'll also discuss drug development challenges for NTDs and use Chagas disease and cysticercosis as examples to identify some of the key issues related to NTD control and elimination. A little bit about myself and experience with NTDs. My interest and exposure to NTDs began in 2010, where I was involved in clinical work in rural Bolivia, and we were working to expand Chagas disease testing. And I also have over 7 years of research experience working on cysticercosis, specifically research related to both diagnosis and treatment. So hopefully I'll be able to share some of the insights that I've gained in my experience in this presentation. Let's start off by talking about the definition of neglected tropical diseases. And this is a definition provided by the World Health Organization. And I think it's a very important one. It really embodies what these diverse diseases have in common. So the WHO defines neglected tropical diseases as a diverse group of communicable diseases that prevail in tropical and subtropical conditions in 149 countries and affect more than 1 billion people, costing developing economies billions of dollars every year. They mainly affect populations living in poverty without adequate sanitation and in close contact with infectious vectors and domestic animals and livestock. I think this last bullet is really important. Neglected tropical diseases affect the poorest regions on the planet and some of the poorest people on the planet. A lot of these diseases are really a result of poverty related to not having adequate development to have better sanitation and things like that. And this lack of and this poverty is also related to close contact with infectious vectors and domestic animals and livestock. So neglected tropical diseases really take into account animal health, human health, and environmental health. And we'll see that these diseases have very complex life cycles, as we'll see with Chagas disease and cysticercosis. And really understanding these complex life cycles give ways for us to think about how do we control and eliminate these diseases. This is the World Health Organization's list of NTDs. CDC also has their own list, but looking through this list, you may recognize some of them like guinea worm disease. Others you may have not have heard of. Typically in the US and in Western Europe, these are not really a focus on in medical curriculums at all. And this is really related to the perception is that these are diseases that don't affect us. But I think as you realize in some of your readings, and as we'll talk about in this presentation, these are diseases that we should be concerned about, not just from a global health perspective, but also from our perspective of health here at home because of immigration and things like that. These are a very, very diverse group of diseases, very different kind of stages. There are some like guinea worm disease that are on the way out, that have many great successes in working towards elimination and eventual eradication. Others have not had great successes, and some and affect affect millions, hundreds of millions of people. For example, schistosomiasis is one that is known to affect upwards of 200 million people globally. Neglected tropical diseases are a leading cause of disability and premature death, and we know that from global burden of disease data. Here you can see it's among the 10 leading causes of life years, loss of disability, and premature death. And the global distribution of NTDs and the people required interventions is not evenly distributed. So here in this map, we can see that the number of people is really highest in the tropics and subtropics. and certain places like India and Nigeria with very high populations, many people affected by NTDs. Um, but this really shows you how widespread these diverse group of diseases are. Shifting gears to emerging infectious diseases, these can be defined as infections that are increasing over time or threaten to increase. These include new infections from unknown pathogens, known infections increasing in geographic spread, and known infections that are reemerging because of antimicrobial resistance or failure of public health measures. The CDC recognizes over 50 emerging infectious diseases. Some are well known, like HIV/AIDS, MRSA, which is methicillin-resistant Staphylococcus aureus, and vancomycin-resistant Staphylococcus aureus, which is VRSA, tuberculosis, influenza, malaria, campylobacteriosis, and of course, very much more recently, SARS-CoV-2 and COVID-19. And there are other emerging infectious diseases that are less well known and relatively rare, things like Hendra virus, hantavirus, pulmonary syndrome, and the Nipah virus. There are some neglected tropical diseases that are emerging and reemerging, and Chagas disease and cysticercosis are examples of this. And we'll talk about each of these diseases separately and specifically talk about their epidemiology and understand why they're emerging and reemerging. Chagas disease and cysticercosis are both parasitic infectious diseases. Chagas is a protozoal parasite. Cysticercosis is a helminth or a type of tapeworm, and we'll talk about these more in a little bit. But first, I want to talk about some of the major challenges on the road to neglected tropical disease elimination. There are challenges that are vector related, related to how these diseases are transmitted. Many are transmitted by insects, animals, other animals. There are disease related aspects, for example, issues related to diagnosis. Drug treatment and development is a major issue we'll talk about more. Social determinants of health. So trying to solve things like poverty in a way to reduce the burden of NTDs. As you'll see later with Chagas and cysticercosis, the life cycle is strongly related to poverty. Environmental challenges, for example, related to climate change and the relationship this has perhaps with vectors, for example, and also disease control. Thinking about how in settings around the world that have very limited resources, how do you develop disease control programs and implement them? One of the issues we'll talk about a lot is drug treatment and development. And this is really a major issue with neglected tropical diseases because we see very little, we've seen historically very little innovation for treating and preventing these diseases. And this has been changing, luckily, but it is a major problem. Many of these diseases do not have adequate preventive or treatment, and there isn't sufficient innovation, especially in the pharmaceutical sector, to make progress here. This is a diagram from the Pharmaceutical Research and Manufacturers of America, and it gives you really a 20,000-foot view of what it takes to get a drug to market. You start in this pre-discovery phase where you're looking at maybe 5 to 10,000 different compounds, seeing which one of those could potentially be a hit. You eventually will take some of those to a preclinical phase where you're looking at animal models of disease. And of those, you really only take a few into clinical trials. Things fail. They don't work in animal models. There look to be signs of toxicity and things like that. And then once you get to clinical trials, you go through these different phases. And eventually, if you are successful, you'll have the opportunity to submit an application for regulatory review. And in the US, before you start studying drugs in humans, you submit an IND, an investigational new drug application. Once you have sufficient data showing efficacy and safety, you can submit an NDA to the FDA, which is a new drug application. And FDA review happens, and if it is approved, it may not be. You eventually will move into manufacturing with the approved drug. And finally, there's a stage of post-marketing surveillance where now that the drug is being given to many people, you can look for adverse events that you may not have been able to detect in clinical trials. So this is a very risky and long road. Risky in the sense that you're trying, there's a very high risk of failure. You start with maybe 5 or 10,000 compounds, and you maybe get one FDA approved drug. So pretty low odds if you're betting on this. And in terms of time, it takes really at least a decade or more to get a drug to market. So this is a very long and risky process, and you can imagine this costs millions and millions of dollars, lots of investment. And when you think about diseases like neglected tropical diseases, it's very hard to convince a pharmaceutical company which has a for-profit business model to invest in drug development for populations that are not profitable in the end. This is a more detailed schematic about what goes into drug development, and this is, I think, helpful to look at what have the different kinds of disciplines and fields involved at the different stages. Here in the first part, in basic science, the exploratory early discovery phase, this is really basic biology, biochemistry, functional genomics, bioinformatics, things like this, really outside of our public health realm. There's different processes here to try to select potentially competitive compounds. And then you move it to a phase of lead identification and lead optimization, where you apply things like medicinal chemistry and animal pharmacokinetics, looking at how the drug works in an animal's in terms of distribution, metabolism, elimination, etc. And in a preclinical phase, where you're looking more at safety, toxicology in animals, certainly before you can start using an experimental drug in humans, you really have to have sufficient knowledge about the drug safety in a wide variety of animals, not just mice, but there's different protocols out there looking at different types of dogs and monkeys and things like that. They're all, I mean, there are definitely ethical procedures there in place to make sure that these animals are treated with the dignity expected in a research study. And once you do get to clinical trials, there's phase one where you're really looking at safety, tolerability, and pharmacokinetics, which is drug absorption, distribution, metabolism, and excretion. And you're looking, at less than 100 people in phase one. Phase two is what we call a clinical proof of principle, where we're really starting to look at how does this drug work in terms of the disease. We're looking at doses, what's the best dose. It's also looking at early side effect profile, and 200, 300 subjects are typically involved. And then we get to phase three, which is large scale safety and efficacy studies. And this may be typically, and for a drug, it is at least two large clinical trials, phase three clinical trials, where thousands of people are exposed. And then, like I said before, there's a registration phase. In the US, we have the Food and Drug Administration, similar processes elsewhere, like the European Medicines Agency. And we get eventually to approval, manufacturing, and post marketing surveillance. As I've mentioned, a lot goes into this process, and a key question is if you need to start from scratch. So the neglected tropical diseases, this is a huge amount of research to be doing and a huge amount of money, and you need to find that money to invest in this. So a really important question is if you really do need to start at the very, very beginning, or can you start kind of in the middle and test and with a potential drug and test it maybe for your disease of interest. So drug repurposing and repositioning are two potential options for bringing new treatments for neglected tropical diseases to market. So drug repurposing is the use of an existing approved drug for a new indication. And you've probably heard of examples of this, especially with the COVID-19 pandemic. So drugs like hydroxychloroquine, approved for other indications, but tested, potentially repurposed for COVID-19. And repositioning is a little bit different. So repositioning is for drugs that are not approved for an indication, but they were developed for a different disease, but for whatever reason they may have failed or whatever the clinical trial. So there is some data that exists for them, especially that early in vitro animal data or maybe some early human data as well, maybe some clinical data in later clinical trial phases that support maybe safety, for example. A really good example of a drug that was repurposed or repositioned for neglected tropical diseases was eflornithine. So eflornithine is a drug originally synthesized in the 1970s, and it was thought to be a potential anti-cancer molecule. Its mechanism of action, it inhibits ornithine decarboxylase, which is involved in polyamine biosynthesis, and this resulted in impaired cell division. So I guess theoretically, certainly a role in anti-cancer drug development. Apparently, this drug did not pass muster in clinical trials for cancer indications, but it was repositioned for very, very different uses. It was repositioned as a topical cream for hirsutism, which is overgrowth of hair. So this is marketed in some places for particularly for women who have excessive facial hair growth. This topical cream is has been found to be effective, and it was originally this anti-cancer molecule, but people maybe had hypotheses that it would have an effect for this other indication, or it may have shown some sort of hair um, hair growth inhibition at some clinical trial or something like that. But what's really interesting, it was also developed for human African trypanosomiasis as an injectable, which is a neglected tropical disease. And there were hypotheses based on its mechanism, how it would work in this disease, and it was studied in clinical trials. So it was repositioned for two different very different indications. So this really skipped a lot of those initial steps where you're looking at 5,000, 10,000 different compounds and trying to find a hit. You already have something that you have animal and some human data on, and you could potentially test it in for a different disease. And what's really great about repositioning is that you probably already have some existing safety data, so it's much easier to start clinical trials for different indications. If you are able to conduct a clinical trial for a drug, either repositioning something, repurposing something, or starting something from scratch, um, you have to think about how you're going to be doing clinical trials. Many of these patients with neglected tropical diseases are in these poorest parts of the world, and there are considerations you may not think about from a high resource setting. So things like access to sites, the status of infrastructure. Are you really able to conduct a clinical trial based on the existing infrastructure? The staff limitations. There may not be any capacity for clinical research, and how do you build that capacity? So those are some big questions. And this slide comes from the Drug for Neglected Diseases Initiative, which I'll talk about a bit more later. But these pictures really do highlight some of the challenges. So um, even if there is the will and the resources to study these drugs in for neglected tropical diseases, actually doing the clinical trials is a very, very, very big challenge. I mentioned before that drug development for neglected tropical diseases does not fit for the in the for-profit business model of the pharmaceutical industry. This is just some reality here is that pharmaceutical industry is for profit, and they develop drugs based on getting a return on their investment, recouping the investment for the clinical the whole clinical develop preclinical and clinical development, and also making a profit once it's approved and in the market. So unfortunately, since neglected tropical diseases affect the poorest people of the world, there's very, very little interest from pharmaceutical companies based on their business model to develop drugs for these diseases. However, pharmaceutical companies have emerged as an important partner for NGOs and academia that do research on new therapeutics for neglected tropical diseases. So some examples of partnerships include things like getting access to chemical libraries. So that kind of pre-discovery phase and heat and hit to lead stage that I mentioned before, this very, very early drug discovery phase. There's companies that have catalogs of millions and millions of molecules, and NGOs and academia have partnered with them and been able to explore some of these molecules for neglected tropical diseases. Also, pharmaceutical companies are resources for molecules for repositioning. So if a drug failed in clinical trials for a certain indication, partnering with the pharmaceutical company may allow you to study that drug um, for a new indication for a neglected tropical disease. And that pharmaceutical company can provide a lot of that expert knowledge of clinical development and regulatory affairs that they have. We'll shift gears now and talk about Chagas disease. On this slide, I have at the top a old banknote from Brazil, and on this banknote is Carlos Chagas, and he is the physician and researcher that discovered Chagas disease. And you can actually see in this bill, aside from the portrait of Carlos Chagas, there is a an image of an insect. I'll circle it right here. And this insect is actually the vector that transmits Chagas disease, this triatomine bug. And here is a picture of Carlos Chagas in his laboratory. I just think it's very, very interesting that a country would have this disease featured on the banknote. I think it really goes to show you how important of a disease it is in Brazil. And I think it's nice that a government, a country features the researchers and clinicians on the currency. We'll start by talking about the life cycle of Chagas disease. And like I said before, the life cycles for all these neglected tropical diseases tend to be complicated and involve vectors, other animals, and humans, and a complex interplay between them. So we'll start here at number one. So what happens is that a triatomine bug takes a blood meal on a human, and it passes the feces where it takes the blood meal by the human. And the human, what happens is that they typically, because of the inflammatory reaction around the bite, they scratch or rub, and this gets the feces that contain the parasite into the bloodstream. And I'll show you some examples of the conditions where this tends to occur. But these are nocturnal bugs that come out at night. So these bugs are typically taking blood meals when people are asleep. This is a major problem is that humans are not really aware of what's going on, and then they scratch and introduce the parasite in the feces into their bloodstream. So there's a whole life cycle that happens. So the parasite go actually really proliferates and then enters different tissues. What happens is that this human not only has um, a large amounts of parasites in their blood, but it goes into other tissues, especially the heart and digestive organs. And we'll talk about the clinical manifestations of Chagas disease in a minute. But what's important is that this parasite in the blood is now an opportunity for a triotamine bug to take a blood meal. And this is actually how it gets the parasite in its system to begin with. It takes a blood meal from someone infected with Chagas disease. These parasites develop in the gut and they come out in the feces and they bite someone else who doesn't who doesn't have parasite in their blood, who's not does not have Chagas disease and infects them. So you can see there's a few opportunities here to break the transmission cycle. So thinking here, um, you could potentially treat people with Chagas disease and get rid of the parasite in their blood. And even if a triatomine bug takes a blood meal from these people, it doesn't have parasite to then infect other people with. So that's one potential option there. And really a big benefit of treatment is that reducing the amount of people with parasites in their blood prevents transmission. However, there are certainly other areas to think about. So you may think about the triatomine bug itself. How do we prevent this situation from occurring where it is coming out at night and taking blood meals off of people? So how do we get rid of this bug? That's another way to potentially break this life cycle. This is what Trypanosoma cruzi, which is the causative parasite here, looks like under a microscope of a blood sample. And Trypanosoma cruzi is a flagellate protozoal parasite. This is a picture of a home in rural Bolivia, and Chagas disease is endemic, as we'll see in Latin America. And this is not an uncommon sight in Latin America where there is a lot of poverty. And you do see these rural communities that are where homes are made of these crude materials out of adobe mud bricks and with straw thatched roofs and things like that. The problem with these types of dwellings is that they are very, very hospitable to these triatomine bugs. So all of these little crevices that are you can see in the walls and in the roof are very hospitable to these nocturnal bugs that come out at night. So these are little places, little grooves in the wall and stuff. They stay, and here you can see a triatomine bug coming out, and here's a close-up. But the idea here is that this shows how linked Chagas disease is to poverty, and how vectors are related to poverty. So if someone they had the money to and the resources to have walls made out of modern materials and things like that, they wouldn't live in a place where these triatomine bugs would reside, and therefore they wouldn't be at risk for transmission when they sleep at night. So this really does show you the connection between the poverty and lack of resources and the vectors and how this can result in disease transmission. These triatomine bugs are the species is Triatoma infestans. What's very interesting is that it is a bug known by many different names. And I think this is an interesting kind of study in how widespread Chagas disease is in Latin America, that there are so many different nicknames for these bugs. For example, in Mexico, they call them a chinche, besucona, versus in Bolivia, Argentina, they call it vinchuca. Similarly, in Brazil, which is a huge country, they have a whole bunch of different names for these bugs. And like I said, this really goes to show you how prevalent this disease is and how common these bugs are that so many names exist for them in society. This is a map that shows the distribution of cases of Trypanosoma cruzi infection or Chagas disease based on official estimates and status of vector transmission worldwide. And we can see there is a very, very large burden throughout Latin America. We see especially in Mexico, Brazil, Argentina, but also throughout um, all the other countries in Latin America. So Venezuela, Colombia, Ecuador, Peru, Bolivia. Um, However, in countries with much higher economic development than the rest of the region, like Uruguay here and Chile, we do see that there isn't really ongoing vector transmission. The countries with this darker blue are countries with ongoing vector transmission from the triatomine bug. Places like Uruguay, Chile, and also the United States are countries we see with accidental vector transmission. And countries with the gray dot, you can see a lot of them in Europe, are countries with cases of Trypanosoma cruzi, but without any kind of vector transmission. And how does this occur? And this is occurring because of migration. There is a huge a number of Latin American migrants who live in Europe, in places like Spain, Italy, etc., Portugal, and what you see is that they actually may be discovered later in life that they have Chagas disease. So that's why we do see imported cases in countries with immigration from Latin America, so even in Asia and Australia as well. This diagram depicts the disease course of Chagas disease. So far we've just been talking about infection with Trypanosoma cruzi, but haven't really said why this is such a big deal. And here I'll explain. So first, there's some sort of human exposure to Trypanosoma cruzi. This is through a vector, but can also be through blood, so via transfusion. However, most countries now do screen for Chagas disease in blood donation. There is congenital transmission. There can also be transmission via transplantation. There's accidental transmission. So as we know, with any infectious disease, people who are exposed may have no infection. That's just kind of luck of the draw. But there are some people who do wind up getting infected. These people may go on to develop an acute Chagas infection that is either acute or asymptomatic or symptomatic. And the symptoms are it's very non-specific to Chagas disease, so it's often not detected. So things like fever, malaise are signs of a symptomatic acute Chagas infection. And if people are treated with antiparasitic drug, there tends to be a higher cure rate here. But it's quite unlikely that patients are identified with acute Chagas infection just because it is very nonspecific. There are a minority of people who develop very, very severe reactions from acute Chagas disease, and they may die from myocarditis or meningoencephalitis. But what happens with the majority of people is that after this acute Chagas infection, they go on to having chronic Chagas disease. And what happens is that chronic Chagas disease can either develop in a determinate form or a indeterminate form. The determinate form is the symptomatic chronic Chagas infection, and it causes cardiac, cardiodigestive, and digestive disorders. often very, very severe. As in the case of cardiac diseases, we see heart failure, different types of arrhythmias are in these patients. Um, Digestive disorders, very severe digestive disorders related to swallowing in some cases, um, and other conditions. And we'll talk about more about the specific symptoms in a minute. But what happens is that um, people in this indeterminate form are completely asymptomatic. And however, what typically happens is that patients will be in this acute chronic indeterminate form and eventually cross over to this determinate form, maybe after 10 or 30 years. And what we see is that patients with this determinant form of chronic Chagas disease are typically middle-aged. They've been infected when they were young, and it's only, 10 to 30 years later that symptoms are developing. There are some patients who may live the rest of their life with a permanent indeterminate form, and we can only detect these patients by seeing if they have Trypanosoma cruzi in their blood. And if we treat these people with chronic indeterminate form, there is a lower cure rate, 20 to 60% of cases. If we give antiparasitic drugs to patients with the determinate form, there is even a lower cure rate than the indeterminate form. So unfortunately, not a very positive prognosis. So the idea here is that it would be very good to detect people earlier on and treat them with antiparasitic drug as early as possible. It's also worth mentioning that immunosuppression can lead to reactivation here and cause symptoms of Chagas disease. These are some clinical manifestations of the acute phase of Chagas disease, and these are really related to the bite from the triatomine bug. So there's a Romagna sign. So this child has been bitten in the eyelid, and you can see the swelling here. And here you can see what's called a chagoma, where you see the indentation of where the triatomine bug took a blood meal, and the surrounding area has this inflammation. And other manifestations, like I talked about, that are symptoms like fever, malaise, etc., very, very difficult to specify as Chagas disease. In the determinant phase, what we see are things like cardiomyopathy. So this is a normal heart on the right hand side, and on the left hand side is a heart in a person with Chagas disease, and you can see they have pretty extensive damage. There has been hypertrophy of the ventricles and atria, and fibrosis. And this is really a type of heart failure that is very, very, very poor prognosis. And in addition to this heart failure, they develop all kinds of different rhythm abnormalities with their heart. And on the right, this is an artist's depiction of mega colon and mega esophagus. Basically, what the Trypanosoma cruzi parasite does is it inserts itself and causes local damage in digestive tissue, and this causes the subsequent hypertrophy of tissue, which then really impedes different digestive processes. So, like I said, patients may have trouble with swallowing and throughout the whole entire, and then issues throughout the whole digestive process. And patients may have a combination of both these cardiac and digestive symptoms. We do have some antiparasitic drugs that we know are um, efficacious for Trypanosoma cruzi infection. And based on the diagram I showed you guys previously, And we know these should always be offered to people with acute trypanosoma cruzi infection, individuals with early congenital infection, children with chronic infection. However, there is some uncertainty with certain groups. So people with the indeterminate form, there's, like I said before, there seems to be a much lower probability of cure with these patients, and also patients with the determinant form, especially ones with mild to moderate cardiovascular disease. So this was actually explored in some clinical research that I'll describe. Here's a trial called the Benefit trial. It was a randomized trial of this antiparasitic drug benznidazole for chronic Chagas disease cardiomyopathy. I show this patient characteristics at baseline just to kind of illustrate to you the burden of disease that patients with Chagas disease have. So the mean age here was 55 of this standard deviation of 10. So these are middle-aged individuals. So certainly not very, very old. But what we do see is that they have a very high prevalence of heart conduction abnormalities described here. And also, they all have heart failure of different severity. And we also can see that these patients are quite sick based on this and on a number of different drugs. Some already have pacemakers implanted. And so the idea here is, can we treat them with antiparasitic drug, and will this have any effect on on meaningful outcomes with regard to their cardiovascular disease and 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 maybe a mortality benefit. This trial found that PCR conversion rates. So um, This is a parasitological cure. So these patients all have parasite in their blood. At the beginning of the trial, PCR conversion is freedom from parasite in the blood, and we can see that benznidazole is more effective than placebo. However, this effect seems to wane over time. Um, we see a 66% versus 33%, so about twice the PCR conversion rate versus placebo, but this diminishes to 46.7% after 5 years. We do see some evidence of parasitological efficacy, but this does wane over time. Perhaps what's most disappointing in this trial is that the benznidazole treatment did not have a significant effect on the primary outcome. The primary outcome was death, resuscitated cardiac arrest, sustained ventricular tachycardia, new or worsening heart failure, pacemaker or implantable cardioverter defibrillator, stroke or transient ischemic attack, systemic embolism, pulmonary embolism, and cardiac transplantation. So all very, very severe outcomes, and unfortunately, it doesn't seem to be like um, benznidazole had an effect here at all. So disappointing. Uh, so it does not seem like there is an effect here in these patients with existing cardiovascular disease. So this really does show us that we should try to intervene earlier, and maybe even think before these patients get infected, other areas of the life cycle that we can interrupt in order to prevent people from getting infected and having these horrible symptoms. However, I would say that even though we want to focus on these more upstream causes, it's really important that we still do a lot of research for these patients as they are sick, and we need to give them answers somehow. Another aspect explored in this trial was safety, and we do see that um, certainly benznidazole was not a benign drug in terms of safety. There were some serious adverse events here, certainly at a higher rate than placebo. So that's is a very important consideration. So when these patients already have such severe disease, what is the benefit versus the risk of giving them this drug that doesn't seem to have a significant effect on on outcomes aside from the parasitological cure. So something to weigh in balance, weigh in balance with the benefits and risks. I'll talk a little bit about the Medicine Sans Frontières experience based on what I've seen with my own eyes in Bolivia. So Doctors Without Borders, or Médecins Sans Frontières, has treated patients with Chagas disease since 1999 and has worked in Bolivia, Guatemala, Honduras, Mexico, Brazil, and Nicaragua. They've Some major focuses have been on vector control and prevention and expanding treatment access. In this image, we have someone from Doctors Without Borders explaining to a member of this community some of the work they're doing in testing. So this particular community in Bolivia has a population of 100, and of those 100 people, they found 29 people positive for Chagas disease. And how many were men, how many were children, how many started treatment, how many stopped treatment or whatever. So this is a really important way to engage these communities. It's really important to get these communities trust and engagement in order to interrupt the transmission of Chagas disease. So testing these populations and getting access to treatment is one very important goal here of Doctors Without Borders. In addition, obviously things like vector control are also very important. So, this really does help upstream preventing infection. This doesn't solve really the root cause of all this, which is poverty, right? But it does solve one of the issues here in the set transmission cycle, where we have these triadenine bugs. So this should have a beneficial effect in interrupting community transmission. Drugs for Neglected Disease Initiative has done a lot of work in drug development for neglected tropical diseases, but really really one of the only organizations out there that has taken this colossal challenge on. And there was a problem previously in that there was no pediatric formulation of benznidazole, which is the antiparasitic drug used to treat Chagas disease. Only 100 milligram tablets were available. And for children, we treat them based on their weight. So we use weight-based dosing. So a child, who is 8 years old receives a much different dose than an infant, for example. So for depending on the weight of the child, you may need to cut up that pill into 12 different pieces and dissolve it in liquid. And this is a problem because there's a very high risk of improper dosing, and side effects related to improper dosing and treatment failure. You give too much, you give too little. And we know that this drug is probably most effective in the first year of life, and certainly in children in general compared with adults. So by trying to cure these children of this parasite early on, we know that this should probably reduce the risk substantially of having disease later on in their life. And the Drugs for Neglected Disease Initiative, what they did was they developed, they tested, they registered, and worked with a pharmaceutical company to manufacture a 12.5 milligram oral disintegrating tablet. So this isn't a problem with having a new drug for Chagas disease, but it is a challenge with the existing drugs. And this organization was able to solve this problem with some efforts related to getting a new formulation to market and partnering with industry to get that done. So this is a huge win for children in Latin America. Drugs for Neglected Disease Initiative has also worked on um, new therapeutics for Chagas disease. As you saw from that clinical trial, benznidazole, the drug we have, is not an amazing drug. There's, it has, in terms of efficacy, it's many limitations, also in terms of safety. So, Drugs for Neglected Disease Initiative, they partnered with the pharmaceutical company Eisai to reposition a drug called E1224 for Chagas disease, and they tested it in clinical trials. You can take a look at this link here. I'd highly suggest it. It's a very, very interesting story, and this is a short video. But unfortunately, what they didn't find that E1224 was a magic bullet here, unfortunately, and but it did provide additional data, and it does show you that this process of drug development is risky, and you can have failure at any stage. But it really does show that we can't give up, and we do need to study drugs for neglected tropical diseases given this risk. So why is Chagas disease an emerging infectious disease in the U.S.? And you can see here, this is a table showing estimated cases in the United States and confirmed cases in donated blood. So a lot of people have actually been diagnosed with Chagas disease. They try to give blood, and since we screen for Chagas disease, they're identified as cases. And I think this analysis took into consideration other factors like immigration rates from different countries and things like that. And they were able to estimate the number of cases of Chagas disease in the United States. And, there were about 2,000 cases based on actual confirmed cases on blood donations, but an estimated 238,000 cases, and this was in 2000, from 2007 to 2013. And obviously, this is a pretty substantial size population. And one of the readings you guys did was looking at was a cross-sectional study at a hospital in Queens with a large Latin American population. They did find a substantial proportion of patients who had heart cardiovascular disease had Chagas disease as well. And we can certainly see that states with a really substantial migration from Latin America is where these patients tend to be. Here is a map of these results. So we do, like I said, places like California, Arizona, Texas, Florida, Illinois, New York, certainly large proportions of Latin American migrants, who migrate to the United States. They don't know they have Chagas disease, and these patients are all at risk for cardiovascular and digestive disease later down the road. And for women who are reproductive potential, it's very important because Chagas disease can be transmitted congenitally as well. We'll talk about cysticercosis now. The reason I put this image on this slide, it's a pig drinking water in a slum community. This is really where cysticercosis is transmitted. We'll look at the life cycle in the next slide, and this really does help you imagine the conditions that generate this disease. Let's talk now about the cysticercosis life cycle. And as you can appreciate, like Chagas disease and other neglected tropical diseases, it's a complicated life cycle between humans, their environment, and animals. We'll start here at number one and make our way around. But what happens is that humans are infected uh, by eating raw or improperly cooked pork meat from an infected pig. And these infected pigs are infected with Taeniasolium, which is a pork tapeworm. As we'll see, these are encysted larvae in the pig's muscles, and when these are undercooked, they can be consumed by humans. So what happens is that humans, as the definitive host, cysticerci, which are these encapsulated larvae, release from the pork meat into the stomach. The pork meat was raw or improperly cooked, so these are still alive. And what happens is that in the human digestive tract, they mature into an adult tapeworm that attaches to the intestinal mucosa by the scolex. And the scolex are these kind of suckers you see here. But this tapeworm, the adult tapeworm, can grow to be very, very long and in the human digestive tract. And what happens is that that the tapeworm begins to shed eggs that are in the human's stool. So we have these Tiniosolium eggs from human stool, and what happens is that pigs ingest these embryonic eggs because these pigs in poor conditions, like we saw in the previous slide, they're roaming around and they're drinking water that has human sewage in it. And so what happens is that after consuming these eggs, they hatch into the intestine. They migrate to tissues, and they develop these cysticerci in the pig muscles, and then the pig is slaughtered for consumption. And these encysted larvae are in the pig's muscles, and then they're consumed. And if undercooked, this whole process continues. But what happens, what really causes disease, is when humans are the accidental intermediate host. So what happens is when instead of pigs eating the eggs in the human stool, other humans eat the eggs. So, because of fecal contamination, contaminated food, water, or auto-infection, where a person infects themselves from their own feces. Similarly to the pig, these embryonic eggs hatch and release into the intestine and migrate to the tissues. And cysticerci then develop in the muscle, they can develop in the eyes, and they can also develop in the central nervous system. And neurocysticercosis is cysticercosis of the central nervous system. And that's when these cysticerci have made their way to the central nervous system and have set up shop as larval cysts in the brain and the rest of the central nervous system. You can think of there's several areas where we can intervene here. A big area where we can intervene is here. We can prevent pigs from eating human stool that has Tiniosolium eggs in it. So a big way we can do this is have humans use latrines and other types of toilets and things like that to keep human sewage away from animals. So this is really a big area here. Certainly, more downstream, you can think about the you know pork meat should be fully cooked and etc. So that's another consideration over here. But this is a big issue here is keeping pigs away from human feces. And another area is with humans becoming the accidental intermediate host. So sanitation and hygiene related to these humans that have the adult tapeworms, they should be washing their hands and things like that. We should try to treat these people, get rid of the adult tapeworm so they're no longer shedding eggs. But things like hygiene are also very, very important here. Cysticercosis is a very, very old disease. So these tapeworms have been seen in mummies, or the remnants have been seen in mummies from ancient Egypt. So we know that cysticercosis has been around certainly 3000 BC with the ancient Egyptians. We know, looking at the Bible, the Hebrew Bible and Leviticus, and also the Quran, that say that pork is prohibited to be consumed because it's an unclean animal, etc. This is thought to be related to cysticercosis. And then later on, really the first human case was in the first reported case in the 16th century to modern day history. But we certainly have this very, very old history of cysticercosis and evidence that it's been around for a very long time. This is what muscle cysticercosis looks like in a human. You see these nodules here, and this is basically the larval cyst. And this is something that patients can have um, dozens, even hundreds of these larval cysts. Similarly, like a pig can also have these cysts. Also, cysticercosis can develop in the eyes. They're in various parts of the eye, so extraocular muscle, eyelid, subconjunctiva, optic nerve, intraocular. So here are some images here to the right. Neurocysticercosis, like I said, is cysticercosis in the central nervous system. And this is a really, really big concern. Diseases of the central nervous system, very difficult to diagnose, very difficult to treat. When you think of resource limited settings and interventions like neurosurgery, that's it may be impossible to do it in some places of the world, right? But the idea is that this is a very, very severe, it can be a very, very severe disease. Here we have cysts in the spine, in the ventricles of the central nervous system, the subarachnoid spaces, the parenchymal brain tissue. So it can occur throughout the central nervous system. The larval cysts have four different stages of life, and this is looking at neurocysticercosis in the brain. We can see that here we have what we call vesicular cysts, are live cysts, and these are the larvae are encapsulated, and this little hole in the dot that we can see here, these little white spaces, are actually the scolex of the larva. What happens, like with all living creatures, they eventually die. So the cyst starts to degenerate, and it causes edema in the brain, which is a result of the inflammatory reaction. The cyst kind of hides itself from the immune system for potentially many, many years. But when it starts to degenerate, the body recognizes it and mounts an inflammatory response, which causes swelling in the brain. Eventually, this little cyst can completely resolve and disappear, or it can form like a little calcified scar in the brain. There are many potential clinical manifestations of neurocysticercosis. In fact, it can cause any neurological symptom. We see that seizures are the most common neurological symptom of neurocysticercosis, but really things that include gait abnormalities, focal deficit, visual changes, even psychiatric symptoms have been reported. So it's very non-specific. Interestingly, neurocysticercosis can also cause no symptoms at all. So these larval cysts that are set up in the brain can be completely asymptomatic. So we have very, very different ends of the spectrum where neurocysticercosis can cause seizures and even epilepsy, really chronic neurological symptoms, or it can be completely silent. This was a study done in a rural village in Mexico, Tepezcintla, in rural Puebla, and they did CT scans at a population level in this population-based study, And they found that 9% of apparently healthy people who never had neurological symptoms actually had these calcified lesions, which is evidence that they at one point had live neurocysticercosis cysts in their central nervous system. This map shows the endemicity of tinea solium and therefore also the global distribution of neurocysticercosis and cysticercosis. So we see really in throughout Latin America, Sub-Saharan Africa, South South Asia, Southeast Asia are all endemic. Um, there are some regions that are suspected endemic. There are some regions, where there are few pigs with risk factors. So, like in Eastern Europe, there may be some transmission, but it seems unlikely as there's few pigs with risk factors. Really related to how pigs are kept and away from human feces and things like that. And then there's places in the world we have no data. There are some places we know for sure cysticercosis is not endemic. So we know in places like the United States and Canada, cysticercosis is completely not endemic. We don't have issues with pigs eating human feces. Pigs are kept in farms under clean conditions, etc. Certainly the case other places in Western Europe, Australia, New Zealand. In the Middle East, it's a very interesting story too. There are no, pigs are not raised in places like Saudi Arabia and Iran. These are Islamic countries where consumption of pork is forbidden. And because there are no pigs, there is no cysticercosis. It's as simple as that. However, for the rest of the world where pigs are consumed, pigs are an important part of diet, economic importance, cultural importance even. So we do see cysticercosis where pigs are consumed and where pigs and are kept in unclean conditions potentially. However, similar to Chagas disease, we do see imported cases of cysticercosis in places like the United States, Western Europe, where we do have migrants from endemic countries who, they present with neurological symptoms like seizures and stuff. You do diagnostic imaging and you do find neurocysticercosis. And this is a result of their exposures in their home countries. The diagnosis of neurocysticercosis is very, very complicated. It requires um, imaging through CT and or MRI. It requires some sort of laboratory capacity to look at serum or cerebral spinal fluid for different immunological tests. It also involves symptoms and potentially epidemiological criteria like travel history or where an individual has lived based on a country's endemicity. It's very, very complicated. Different criteria for types of neurocysticercosis depending where in the central nervous system it is. This is some work I was involved with in Latin America, and we developed diagnostic criteria and examined the validity of these criteria. But it does really require a lot of resources. It requires a lot of a lot of things like tangible resources like MRI machines, CT scanners, laboratory capacity, but also less tangible resources. So things like human resources that, having neurologists that are able to diagnose this disease as it is really does require that really specialized training. As I mentioned, MRI and CT are needed for diagnosis of neurocysticercosis. And these are graphs showing MRI units and CT scanners per million just for the OECD countries. And we can see the only country that is endemic for cysticercosis among these has lowest access to MRI and CT. And in countries and other countries, Mexico is actually quite a high resource country. In countries that have fewer resources, such as in sub-Saharan Africa and places, for example, Malawi, there may be not even a single MRI machine. You have to go to a different country. So very, very limited access to MRI and CT in countries that are endemic for cysticercosis. So this obviously presents major, major challenges. If you need these tools for diagnosis, people who have the disease are not going to get diagnosed. Another issue, as I mentioned, is related to human resources, and this is a news headline from a paper in Bolivia. So it says in Bolivia there are 50 neurologists for 10 million inhabitants. In other words, one neurologist for every 200,000 people. So a very, very, very low ratio. So according to the Bolivian Society of Neurology, there really should be one neurologist for every 2,000 inhabitants. But this is really an impossibility here. Only 50 neurologists. So you have to think about in a country that is endemic for cystic sarcosis, how do you make use of those 50 neurologists, and also how do you train primary care physicians and other healthcare workers to diagnose and treat the disease? You can't rely solely on specialists. You certainly it'll be important to train more specialists, but you do have to think about sustainable ways to do that in these settings. One of the articles I asked you guys to read for today is an article that was published in 1992 from the New England Journal of Medicine. It's, I think, a very interesting outbreak investigation. And with neurocysticercosis, it's really sort of a landmark article in that it really illustrates the transmission of this disease. So, what question I want you guys to think about is why an outbreak investigation was done in this community. So basically, they talk about these four patients who had neurocystic sarcosis. They all had seizures. They were different ages, different results on diagnostic results, and they also looked at their family members as well and found that it looked like some of them had also positive serologic results for tinea solium, either antibodies or antigen. I can't remember. But think about why is it so interesting or unique that there were four patients in New York City with neurocystic sarcosis? As it turns out, patients 1, 3, and 4 were born in New Jersey and New York. Patient 2 was born in Morocco but lived in the US since 1976, so something like, more nearly 20 years before. Only patient 4 had traveled to a country that was endemic for cystic sarcosis, and this was 8 years before developing symptoms. What's very strange and why an outbreak investigation was warranted was that these were all Orthodox Jews who have nothing to do with pigs. They don't eat pork. They're not involved in pig farming. They don't have anything to do with pigs. They all live in New York City, an urban place, right? However, neurocercosis was diagnosed in all four. How could they have possibly acquired it? They couldn't have acquired it through traveling to endemic countries or endemic areas since they were all local. So when you read the article, you do find that um, they did an investigation of everyone in their households, and they found that they had employed these some domestic workers, housekeepers that were from Latin America, and they actually had tinniasis, so they were shedding uh, tinea eggs in their feces, and really just because of how closely they're working and with these families and stuff, preparing meals, you know, helping with kids and stuff like that. That is really, you can imagine how these individuals may have ingested embryonated eggs, and how these embryonated eggs hatched and then then went to their central nervous system and set up shop. So it's a very, very unusual case, but it does illustrate those different aspects of transmission, how you don't get cysticercosis just by eating undercooked pork, but it is a much more complicated process where there are people who are tapeworm carriers, where eggs are shed and then are consumed by humans who are an accidental intermediate host and can develop very, very severe neurological symptoms. So why is neurocysticercosis considered an emerging infectious disease in the United States? Well, that outbreak investigation gives you a clue that it can happen here. But we also have a lot of migrants from cysticercosis endemic countries in the U.S. and they may develop symptoms after they've immigrated here, right? And this was some work that looked at hospitalizations and total charges, the financial charges related to these hospitalizations in the United States from 2003 and 2012. And they found that there were over 23,000 hospitalizations related to cysticercosis and over $1 billion in charges related to cysticercosis. So this is a disease that, we may think about it, oh, it only happens in non-endemic countries. Actually, this is something that is really affecting us in the US as well in terms of burden of disease and also the financial element related to the hospitalizations. This table shows the associated diagnoses and procedures for these people who are hospitalized with cysticercosis. And we can see in terms of diagnoses, these are all the symptoms that we know are prevalent and possible with neurocysticercosis. So things like epilepsy and seizure, things like hydrocephalus, headache, mental health disorders, all these different neurological symptoms. And in terms of procedures, obviously neuroimaging, we need it for diagnosis, and this is certainly an important contributor of costs, but also things like ventricular shunts and also neurosurgery for incision or excision of the cysts. This is major results in major costs as well. So we can see, neurocysticercosis is an emerging neglected tropical disease in the United States. Certainly globally, it is a major neglected tropical disease. So it is something we should be very concerned about domestically in addition to globally as well. So that has been our overview of neglected tropical diseases, focusing on Chagas disease and neurosis and cysticercosis as good examples of some of the challenges in disease control and elimination. The World Health Organization has this roadmap for overcoming the global impact of these diseases. And I think it's a very nice place to end this session. So this roadmap for implementation represents the next step forward in relieving and in many cases finally ending the vast misery caused by these ancient diseases of poverty. I would highly encourage you guys to take a look at the link to the WHO roadmap. But what is very interesting about it is that instead of focusing on specific diseases, they focus on populations and intervention. They also focus on the introduction of innovative tools for parasite detection and control, and they advocate for a multi-disease, intersectorial, interprogrammatic approach. For diseases like neurocysticercosis, when you try to address something like sanitation in a community, that may not just be relevant to cysticercosis, but that's probably relevant to other neglected tropical diseases. So you can have these integrated approaches. Similarly, when you're thinking about stuff like improving access to diagnosis and treatment, you're probably going to want to focus on multiple diseases rather than single diseases and increasing capacity for diagnosis, management, and also research for multiple diseases rather than just single diseases. And it really does require an intersectorial and interprogrammatic approach. So you need cooperation from governments, you need cooperation from local communities, from the healthcare sector, etc. So this is a very interesting document, and I would encourage you guys. It does give you a very good global perspective of these neglected tropical diseases. Thank you so much for your attention. If you have any questions, please feel free to email me. I look forward to reading your posts on the discussion board and having some interesting conversations about neglected tropical diseases. Thanks so much for your attention.